All right. Hi, everyone. Good to see everyone. Happy New Year. Welcome to the CADS and the Alliance for Leadership and Education's first webinar of 2023. Happy to see all of you here. And we're scheduled to see around 290 people who have registered today. And I noticed people are still streaming into the room, which is why we waited just a few minutes to get going. Appreciate you all taking time from your busy day to join us today. I'm Lydia Miselides, the Executive Director for the Alliance for Leadership and Education and Interim Executive for the Association for Adult Day Services, and I'll be your host today. Our topic is Emergency Remote Services, Lessons from the First Quarter. This webinar is focused on CBAS providers because we're focusing on a brand new service that just took effect late last quarter, and we do want to acknowledge, however, our Adult Day program colleagues who may be joining us on the webinar today, and also our managed care plan partners who I see are with us as well. ERS, Emergency Remote Services, requires a really strong partnership, more so than ever, with our managed care friends. So we're really glad that you're able to join us today as well. Today we want to illustrate some of the best practices that have emerged from the field through a combination of storytelling and some guidance. As you'll hear later, ERS is a demonstration project under the Federal Centers for Medicare and Medicaid Services, as well as our own Department of Healthcare Services. So you'll hear more about what that means in just a few minutes. Our usual webinar tips: we are recording this meeting. Listen only mode is on. Handouts are accessible using the handouts tab. And please do submit all questions during the Q&A feature. Chat and hand raise features are off, and we have a survey at the end of the webinar, and if we have time, we're going to pop a little poll up during the webinar as well. And I want to ask Danielle, who's helping me behind the scenes, to just ensure that the webinar is being recorded at this time, if you could, Danielle.
And Lydia, I don't think we're able to see the slides at the moment. I think they need to be turned on.
Oh, thank you, Richard. Appreciate that. I'm going to do that right now.
It is being recorded, Lydia.
Thank you, Danielle. All right, give me 1 second, everybody, just to see why it isn't sharing my slides.
If you need help, Lydia, I can share the slides on my end. This is Renee.
Yeah, I don't know why it is not letting me do that right at this moment. We have a question where we can print the handouts. They can be found under the handouts bar, the gray bar on your screen to the right, on the panel to the right. If you pull down that little arrow, you should be able to download the PowerPoint for today as well as another handout. So yeah, go ahead and do that for me, Renee, because I don't know why it's not allowing me to show my screen.
Will you set the settings that allows me to do it?
Yes, I'll make you a presenter. Oh, I see what happened. Yes. Should be good to go.
It's saying that there's no presenter right now.
It just made you presenter.
Okay, make presenter. Got it. All right, show my screen. All right. Let's see here. All right, we're getting there.
All right, thank you.
All right, thank you. Yeah. All right.
Very good. So we'll be on slide 3.
All right. Does everybody see slide 3?
No, just slide 1.
Oh, goodness gracious.
There we go. And can you
Oh,
make
God.
it full mode?
I know, right? It's like it's Friday the 13th or something. All right, let's try again.
There you go.
Okay, there we are.
All right.
All right.
Thank you. So in that little interim of our technology challenge, we're up to about 183 people now who have joined. So those of you who have just come on during this little interlude, welcome. We're going to now look at the agenda. We are going to just do a quick little reminder about COVID-19 and flu. Yes, they are still around. We're going to turn to CDA, and they're going to start sharing some data some of you have seen, but it's up to the date now through December. We're going to also take a look back at successes and challenges that we've all experienced from October through December, some stories from the field, and then Renee's going to close us out with some reminders about paperwork and reporting requirements, and then we'll end up with some news from CADS. So next slide. Here's our presenters today. You see we've got a great team of people from the Department of Aging and our provider leadership team, all of whom are part of what we initially called our crisis team, now is called the vision team, that has been meeting weekly. We're almost on our 3-year anniversary, meeting weekly since March of 2020. Next slide. And you will be able to see here the list of all of those individuals who have dedicated their time, their intelligence, their experiences, their wisdom to helping us all navigate this hopefully once in a lifetime experience of living through a pandemic together, and all of the changes and challenges that has shown us both personally and professionally. So thank you to all of the Vision team members. So now I just want to give you guys a couple of public service announcements about COVID and flu, as I mentioned. The updated booster has been shown to prevent severe disease and death in high percentages. So there's no guarantees with any vaccine, of course, but this updated booster is very well matched to the Omicron subvariant that has been circulating for quite some time, and everyone is encouraged to get boosted if you can. If you are not eligible for any of the original vaccines, and you have not been vaccinated yet, please talk to your healthcare professional for advice on what to do if you do want to start that campaign, or if you have participants who want to start a vaccination campaign. And this slide was interesting to me. Just one other quick back one, Renee, with just the data about one more. The data that shows that the highest incidence of hospitalizations still remains the oldest population, and those with chronic conditions, who are the very people that you serve. So let's protect our participants and protect ourselves. Next slide. And it's not too late to get a flu shot. I thought this was fascinating. That little chart on the right at the top shows you the flu spread very early this year and quickly. And any of you who were unfortunate enough to get the flu know that it's a pretty miserable strain. And so we want to avoid it at all costs. Every year people do die from the flu, whether they're vaccinated or not. The flu vaccine actually doesn't protect even as well as the booster does, the COVID booster. So this is just a little public service reminder to please get your flu shot. It's not too late. We don't know if flu season is going to peak early or it's just going to extend out even longer than normal. So do be sure that you protect yourself and your participants. Next slide. And this is just a quick reminder. I'm not going to spend any time on it other than to say there's a new all facilities letter, 21-34.5. It's a revision of an earlier letter from the Department of Public Health. And the main thing is that You still have to have healthcare personnel working for you that are fully vaccinated, unless they're exempt, but you no longer have to do regular testing of those individuals. So please do read through this all facilities letter carefully. And the next slide I just pulled out to indicate to you, oops.
So sorry, guys. Technical
That's okay.
difficulties again.
That's okay. That's okay. It's just our day-to-day, Renee. The next slide real quick is just a summary of the immunization requirements for healthcare personnel. That's HCP. Okay, next slide. I have now the pleasure of turning this next segment over to Jennifer Jager and Brett Hendrickson. I hope some of you did get a chance to meet them both at the annual conference in November down in Southern California. And they're going to tell us the story that your data tells all of us. So Jennifer, I'm going to hand it over to you right now. It's been exciting to see the data in almost real time come forward.
Absolutely. Thank you so much for kicking us off, Lydia. And good afternoon, everybody. I just wanted to thank you for joining us today, and I hope that you find this information valuable. Before I actually jump into the data, I do want to take a moment just to kind of remind everybody, you know, we are in this together, and we're still learning all of this together. So it's been almost 4 months since ERS implementation, and we're still working through some challenges. Whether they're policy related, procedural related, dealing with reporting or data. And I know that as providers, you know, you face additional unique challenges related to outbreaks, whether it's triaging participants or just day-to-day operations, you know, all while striving to serve a very vulnerable population. So kudos, I wanted to say today, for your continued efforts and diligence through this time of change. It is a intense time of change. And thank you, I wanted to also say today, for working so hard and caring for the individuals that need you the most. So I will be jumping into the ERS data with everyone, which does tell a story of kind of where we have been and where we're at currently. Before I do so, I would also like to recognize and thank our CBAS data analyst, Brett Hendrickson, who makes all of this happen behind the scenes. So thanks, Brett. Okay, so current ERS events. So this data is actually a snapshot in time. So it does, it's current as of yesterday. So January, for the week of January 26th. So remember, these numbers that we're looking at here are a snapshot in time. So CDA has been collecting SIF data regarding ERS since implementation. As you can see on the screen, there are currently 4,756 current or open events. Of those, 2,558 are personal emergencies. So the personal emergencies consist of serious illness or injury, crisis, and care transition. Then we move to 2,198 public emergencies. So those do include power outage, epidemic infectious disease, and outbreak. Also on the current ERS events, we show that out of 280 open CBAS centers, 147 of those centers are currently utilizing ERS. We also calculate approximately of the 36,000 CBAS participants, 13.2% are currently using the ERS service modality. Also on the same screen, we're going to move to the pie chart. So this data is representative of October 1st, 2022 through yesterday, January 26, 2023. So this is from inception of ERS, and as you can see here, the largest ERS category since inception is the epidemic infectious disease outbreak. So it does make up about 52.9% of the total ERS events. The next largest ERS category since inception is serious illness or injury, which equivalates to 31.5%. Next slide, please. Another great snapshot here. So this kind of tells story of active ERS events over time. We created this internally, so we didn't start tracking this till it looks like November 3rd, but it does go up until yesterday. So this is kind of trending the data over a course of November, December, and some of January. We're not quite through the month yet. So this data tells a story that around the end of November, the initiation of ERS under CBAS did start to increase. So this was kind of during the height of the winter. December indicates the highest use of ERS with the largest category of the epidemic infectious disease outbreak. Since January 5th, we've seen slight decrease in the overall, not in the overall use of ERS, also a decline in the epidemic infectious disease outbreak. So it is starting to decrease. Hopefully we continue to see this decline over the course of the next few months as well. So we'll continue to trend this data. Next slide, please. Okay, this represents, since inception, the statewide utilization rate. So started in October, we have seen a statewide decline in utilization. So during November and December, the utilization rate remains low at 57%. It really hasn't budged over October, November, and December. And so pointing this out may be an area of concern, but in reviewing the monthly statistical summary report, which is the MSSR data, alongside the UR data, we have seen new enrollees, which is good news. So if discharges taper off, then we do remain hopeful that hopefully UR will improve. So again, CDA will continue to run the data, continue to analyze and trend the data, and share it out, report it out moving forward as well. So thank you for allowing me to go over the data. I believe I'm going to kick it off to Denise next.
Yes, thanks, Jen. Getting my camera back on here. Hi, everyone. Thanks for joining us today, and thanks, Kads and Lydia, for inviting us to participate here. So Jen gave us a good look at the numbers there and where we are present day. And I think we're going to just cover quickly, if we can get to the next slide, just cover quickly some of the things that we think are sort of in the look back of the last few months that we can consider to be successes, and then some of our challenges that we continue to deal with. So just quickly, I wanted to mention that, and again, it goes along the lines of the thank yous and the positive remarks that Jen opened with there from CDA's perspective. We got this thing called ERS started in an awfully big hurry. So we moved from, well, we moved rapidly to respond to COVID. We went through the initial couple of years of that, and then we thoughtfully, with all of you, worked our way back into a transition to full in-center services and the end of TAS beginning 10/1 of 22. So that all was a huge success, of course. But the biggest success, I think, that in this quarter has been that we got this brand new modality in the CBAS benefit, the emergency remote services, and what we did over a very short period of time was to get it up and running by 10/1. And I think remarkably, in that short period of time, all of us got a lot of things done well and done right. So I think we can all be pretty proud of that. Most of the participants returned to center-based services. That's another big success. So we had many of you will remember early last summer, we polled all of the providers to find out the number of anticipated discharges, et cetera. And we had fewer discharges than we had anticipated based on those numbers. So that was really good news. So we avoided some discharges. discharges. And on that note, we had some pretty fresh data from Brett, our data analyst, just yesterday, where we looked at a number of the participants who were projected to be on that discharge list who were actually served through ERS. So that's good news too. I think that there were close to 900 participants that perhaps would have lost services that managed to get some emergency remote services through this new part of the benefit. So that's really good news. That next far box there where it says it's been used but not overused. So Jen showed you a stat, and I'm going to say it was around 13% of the participants who've received ERS. So again, I'd say good news is that especially during the transition back to center-based services, that those numbers could have been a lot higher. And in fact, we've gotten a lot of our folks back into the centers. It's been very effective in dealing with both public emergencies and personal emergencies, and teeing that up for our provider presenters who are going to come after me here. They're going to be sharing some of their personal stories at the center about that. So both public and personal emergencies related to floods and outbreaks with the public, and the personal emergencies, injuries, illness, etc. So we think we got some pretty good categories for how to use this benefit, and so that's been a big success. It's been very collaborative, as Lydia mentioned at the top of the hour. We've been learning together and doing quality improvement. We have more to do, but we've been doing an awful lot of it, and that's really good news too. And then that data that you just saw that Jen presented is all brought to you by a lot of effort on the part of CDA in investing in our IT systems. We're still working on getting really good data reports out and trends to look at, etc., to further refine and improve things. But that data capture process at CDA has been a really big success. If we can flip the slide. A look back at some of the challenges, and some of these are continuing. So we have to acknowledge there's been a steep learning curve for all of us, providers, CDA, the state, the DHCS, and managed care plans. We've all been, like I said, putting this thing together very quickly and responding to the needs of our participants and their families. And it's been a lot to learn over a very short period of time. And there's been a lot of complexity to this new service. So I think that, by next year, we're all going to be looking back and saying, oh yeah, this was this is all a known quantity now, and we know what we're doing with this, and we fine-tuned it. But there was a lot of complexity to work with fairly early on. Variations in implementation. So yes, this has been a challenge. So we've had, and that kind of goes to the next little box there too, about underuse by some providers. So we have managed care plans who've had a lot to learn with this, providers who've had a lot to learn, participants. They didn't understand a lot of why they were losing their tasks, and why they were going to need to either be back in the center, or under some circumstances, if they qualified for ERS, to be able to get some services. So various things that have happened at different centers and in different managed care plans have added to some of our challenges. Some of our providers have underused the benefit, and we're not really sure. CDA is looking into what that might be about, where we have some providers who have not used ERS at all. Why is that? Is there hesitancy among them? Is there concern that something might not work out with the managed care plan when the provider sends the SIF in, and there might be a disagreement about what needs to happen? That might be a barrier. It might not be that. We're still looking into this. What are the issues around that? Or do some providers not really feel clear about how the benefit is to be used? So there's a number of possibilities, and we're exploring that. Now. I think there were about 100, Jen may have referenced that, I can't remember, that providers who have not actually used the ERS for any of their participants. So if participants who need it are not getting it, that's a concern. just as overuse would be. There's new needs for communication and coordination. So we recognize this, and many of us sat in on an LA Care webinar yesterday. Really good information sharing there from LA Care to the providers about how they are coordinating with this new ERS and a number of other CalAIM benefits. So lots of more communication and education and coordination is part of our challenge. And then the administrative burden, I think that we can acknowledge that it's been higher than expected for all, for the state, for providers and managed care plans with the paperwork and related delays, et cetera. So there's a number of things that we're going to be working on refining going forward. The one thought I'd leave you with is that I think I'm humbled by looking at the numbers that Jen presented, thinking about that each of those numbers represents a whole lot of people who are served, your participants and their family members. They have stories, they have had needs met, they've been going through an awful lot of change. So I think that that's a really important part of the story for all of us to remember, and as well as, of course, all of our own provider, state, managed care plan efforts that are behind those numbers as well. So with that, I'll look forward to taking questions later on and pass it back to Lydia or to our presenters, provider presenters. Thanks.
Yeah, thank you, Denise. Well, we actually are on time, so I'm going to just pitch one question to you, if you don't mind coming back, because I know this comes up frequently. And it's the question from Manoush about, are there any plans about developing a hybrid program? And rather than me answering that, I thought it might be good for you to make a statement publicly about this, and then I'm going to launch the poll after you're done with that question.
Sure. Thanks, and hi, Manoush. So the quick answer is no at this point. And so I think that the hybrid concept was something that existed in TAS, and when we move forward into ERS, that was a part of the past. So with ERS, with regards to how it is utilized, it's possible that there may be refinements around some kind of transition in the future, transition periods, but that is not anything that's been decided at this point. I think our vision team members have put forward some requests, and they may be talking about requests of the department, but they may be talking about that at the end of the slideshow. But as of right now, absolutely no to the overall hybrid question. So, and for anybody who doesn't really understand what that means, it would be a combination of participants being served, I guess, in the absence of an emergency through both in-center services and remote services. So that's a no for now, Manoush, and thanks.
Okay, thank you for that, because I know that's a question that comes up quite a bit, Denise, and we're all kind of grappling with it. So everybody, we're pretty much on schedule, so I'm going to launch a quick poll. This is the only one today, so please do participate. And the question is the following. What are your biggest barriers to implementing ERS? So here's just a few ideas that we came up with. We can only choose 5 options on GoToWebinar. So if you wouldn't mind taking a moment to answer that question. And this will also help us with future trainings and maybe some FAQs, Q&As. Department and CADS and ALE are dedicated to helping you all navigate through this next phase of change. Okay, I'll leave this open for just another minute. 30%. Oh, I really like to get it up to 50%, everyone. So please take a minute and vote. All right, so I'm going to leave it for just another minute. We're at almost 50%. So it's looking like the majority, 44% of the answers, anyway, the majority of the answers are saying a lack of clarity for managed care plans as to their requirements. So a little more communication sounds like it's needed there, or understanding at least. Close behind is paperwork is new and process is new. It takes a little bit too much time. We have heard that from some folks. Only 11% say they haven't needed to use it yet. 32%, 31% now say managed care denials are discouraging. And 30% the policy is not well understood and don't want to make a mistake. So thank you for those responses, everyone. That is super helpful, and it's consistent with what we've been hearing from folks and actually some of our discussions with Vision Team. So appreciate that. All right, so I'm going to now hand this over to our panel. I'll look back. Stories from the field is our next topic. And I'm going to invite our panel members to join me for a moment here while they get on camera. We're going to now hear a story from each of these 4 panel members. We're going to start with Lena, Richard, and then go to Tatiana and Loa. So each of you can introduce yourself briefly. And these are all Vision Team members who've been working since March of 2020, as I said, and have contributed to these webinars, to our intellectual work, to our little family of Vision Team folks who really are here to help all of you. So we're going to start with Lena. I'm going to go ahead and go off camera when you're finished with your stories. Then we'll do a little bit of Q&A among yourselves, and then we'll move on. So take it away, Ms. Lena.
Thank you, Lydia. Hi, everybody. Lena Hartunian, Program Director at New Sunrise ADHD. I'm happy to be here today and doing these webinars again. As far as public health emergencies and outbreaks, our center experienced an outbreak, a COVID-19 outbreak, 1 week before October 1st, and we had been providing in-center services since February of 2022. So we were kind of sad that we had to pause right before we had to all come back into center. Nevertheless, it was a difficult decision to make, but for safety reasons for the participants and the staff, we paused in-center services a week before October 1st. And that was helpful for me to experience prior to the start of ERS, to be able to switch to remote services, identify participants who continue to need our services during the pause. However, now that since October 1st and the start of ERS, as a provider, as a program director, knowing that the ERS and the flexibilities available to us under ERS is still available if needed during another outbreak. And of course, this is not TAS. ERS is different, even though it provides flexibilities. And it gives us the opportunity when submitting SIFs to collect data that we never were able to collect before. So ERS is a wonderful thing. And we've had to use it for some of our participants, and we're grateful to be able to provide those services to our participants.
Okay, I'll take over since I think Lena's done. Hi, my name is Richard. I'm the program director at Beverly Adult Day Healthcare in Los Angeles. And I guess my bit of the outbreaks kind of situation was we actually had to pause in-center twice, once in October when we started congregate services, as well as in December for our last one. And we were closed for a couple of weeks for each circumstance. And for us, the biggest challenge was decongregating, so taking an in-center program and then moving it back to remote, basically at the drop of a dime because it was due to COVID. And then the other challenge was bringing them back in once, the pause was finished and once the crisis was over. I think with any program, and especially with TAS, it was a little bit stagnant because we were in a remote program for so long that people got used to and kind of trained to be a certain way and to receive certain services in a certain way. But doing this flip in a matter of weeks, it really throws people off. If you have participants with dementia or even family members that need to coordinate these things in terms of remote services, if you're doing them through ERS and then moving them back into congregate, I think you always, as a provider, have this situation where participants either don't understand or are not able to fully comprehend the situation or the kind of crisis at hand. And so we always had participants either not wanting to come back or not wanting to leave the facility, I think, which is kind of our problem as providers, right? Because we need to be the ones that fully comprehend what ERS is and how it needs to be used. I think for the beneficiaries or the participants, they don't need to fully know what ERS is, but they need to be, cognizant of the services that are going out. And so I think I just wanted to highlight this specific challenge with using ERS in that it's not it is a silver bullet in the sense that it helps you when you're under crisis in terms of an outbreak, but at the same time, it does have these reverberating consequences that affects the participants as well as staff members because you're doing this back and forth in a very short-term period. And so for us, I think even though it's a challenge, I think we were very fortunate to have ERS and still have ERS so that it's kind of our insurance policy in the case that we do have outbreaks. But I think the biggest help through this was reaching out to our managed care contacts and making sure that we understood what they wanted from us when we were going into ERS, as well as reaching out to our CDA partners. And as Jen said at the beginning of the webinar, it's a process for everybody and it's new. And so I think working through it with CDA and the managed care partners really helped us to streamline the process so that we didn't feel unsure of, whether we were going to get paid, whether these were, legitimate services that we were thinking of and all those things. But yeah, that was mine. And then I'll turn it over to Tatiana.
Thank you, Richard. Everybody can hear me, right? Awesome, thank you. I was having a few technical difficulties today. So good afternoon, everyone. It's a pleasure to be here and with you this afternoon and to have the opportunity to present and to share our provider experience. My name is Tatiana. I'm the program director at Golden Castle Adult Day Health Center in Palo Alto. And our center resumed in-person congregate services in May of 2021, so just when it was slated to do so. And while we had several COVID cases, here and there, we actually had no outbreaks, official outbreaks as defined in 2208 until September of 2022, as the COVID variants became more contagious and spread more easily among our participants. So our first outbreak, again, in September of last year, was linked to a single dining table, and it was spread between several participants who sat at lunchtime together. And it was a pretty straightforward decision to close. We followed the 2208 ACL guidance, which said that we were to use our best judgment and to link cases epidemiologically to 3 or more. And, if those cases were linked, it was a straightforward decision to pause in-center services, follow the reporting requirements of filling out and submitting incident reports, making contact with the local health department, and basically doing an all online program because this was still during task times, right? Temporary alternative services, where it was kind of easier to start and stop. However, just recently, this past December, mid-December, we had our second in-center pause, which to us wasn't as straightforward, and that's why my segment is called "I Waited Too Long to Pause," because several participants developed COVID. However, they were all in different times throughout almost a 2-week span. And those participants that did get COVID all sat at different dining tables. They participated in different activities and were even in different wings of our facility, making contact tracing easy, however, linking them epidemiologically a little bit more difficult. And it was only close to 2 weeks after the initial cases came up that we were able to link 2 additional participants, a husband and wife, to a participant who got sick a week prior to that. So those 2 additional cases were the epidemiological links that we needed to finally make that decision to pause, as we were already at 3 cases, and switch to ERS. So the first few days were actually dedicated to triaging participants and their needs, setting up doorstep checks, schedules, preparing meals, activity packets, exercise guides to be delivered to participants that were enrolled in ERS, while pivoting back to online activities and exercise groups that have ended during tasks, so that we can deliver those remotely once again. And some participants who were enrolled after the end of tasks needed a lot of technical assistance to access online programming. So we scheduled a lot of home visits that were attended by our tech-savvy social workers, and to make sure that we were able to assist those participants to access all of the online activities and exercise groups that we were offering. But because the pause occurred just days before the holiday season, we decided to wait to resume congregate services for at least 1 week after the new year to ensure that we were able to catch and manage any potential new infections that could arise after holiday celebrations. So our pause lasted about 3 weeks, and we anticipated, we resumed in-center congregate services on January 9th. And thankfully, it has been all clear since, so keeping our fingers crossed. So with that, I will hand it over to Lois.
Thanks, Tatiana. It really is a pleasure to be back here again, here in I can't believe it, 2023. As you can see, mine is, it's a judgment call as to how long to pause to be safe. And it definitely is. We had a very similar situation to Tatiana, except that it was our first outbreak that happened in mid-December. We had one case that we identified on, oh, my lights go out when I don't move, sorry. We had one case that we identified on December 8th, and then another case on December 9th, neither of which they were in different parts of our program, so we didn't think of them as being connected and weren't too worried about that, but decided that we needed to, because of those two cases, one day after the other, that we needed to test everybody on Monday. And we tested everybody on Monday and found 6 new participant cases and 2 staff cases, and decided, although we didn't have any epidemiological link at that point, we decided that we needed to pause right away. We later found that there was indeed an epidemiological link. There was one person who came in sick on the previous Monday and didn't know he was sick, came down with COVID a couple days later. But it was quite a decision, I'm sure, for those of you who have done pauses the way all of us have. You know what a difficult decision it is to make. It's you have to contact so many people. There's always a worry that you may lose people's confidence because they're afraid they'll get COVID when they come if you've had an outbreak. So it's a really very difficult decision, and we certainly didn't make it lightly, as I know none of you would do. But we decided at the time, in our incident report, I put in that we would close for 2 or 3 weeks, or pause for 2 or 3 weeks, being a little unsure. But that time went over Christmas time, and we could, at the end of 2 weeks, it would have been December 26th. So we would have opened on December 27th. And although we hadn't had any more cases that we knew about, a couple more earlier on, but no more in the last week, we decided that it really would be way too risky and not a good idea to open, just to reopen, to have people come back to the center just after the Christmas holiday weekend. That seemed like it was risky and a bit reckless to do that. So we decided to wait until January 3rd. And we were, as Tatiana mentioned, we were a little worried about the holidays for New Year's, but decided that most of our participants were unlikely to have had such big celebrations at that point. And we have been open since then, and like Tatiana, we haven't had any cases, fingers firmly crossed. So it is a really hard decision, but I think the decision always, always, always is to keep our participants safe. That has to be our first decision always. And I'll pass it back to Lydia.
Thank you for those stories, everybody. And it's really triggered some great comments from the audience that I'd like to pitch to you. We're not going to have each of you answer a question, but I'll pitch it to you guys as I see fit. First thing that came to my mind, this isn't a question from the audience, and I'm going to pitch this to Richard. Could you explain how you communicated with your managed care plans? You have multiple plans in LA that you contract with. So what was your first thought when you decided you really did need to pause for a bit?
Sure. I think just as a comment of reassurance, even though, I'm on Vision Team and I'm part of, these conversations, for our center as a program director, even for myself, I wasn't sure what was going to happen when I sent those SIFs into managed care because I wasn't sure if I was doing things the right way. And I think that's for any program director or operator that's, going into ERS, because with TAS, we've been doing it for so long that we were kind of used to the rhythm. But since this is a new program, I was very unsure if I was going to get, approved in a sense, if, we considered an approval, if the notification was really a notification. And so the first thing that I actually did just to, allay my own fears and for our center is to reach out to our managed care department via email, managed care organizations via email, and contact them and, make sure that they were apprised of our situation. We have this X number of people that do have COVID that are testing positive. We foresee sending these many SIFs in, and that we wanted to make sure that they were prepared for it as well. I think, even on the managed care side, they have their departments, but when you send, 50 to 80 forms in all at once, I think that can get overwhelming to the department that's receiving them. And so just giving them a heads up and giving them the context on why these are coming in or why centers are sending them really does help, solve a lot of the operational hiccups that might come up. Because in that case, if you're sending one that's wrong, most likely every one that you're sending is wrong in a certain, technicality. And so I think that's the contact that I made with managed care and the different departments. And of course, I think everybody knows that each managed care plan does things a little bit differently. And so knowing that from my side as a program director made it a lot easier to initiate, these SIFs and the ERS situations, and also give them a timeline of, hey, I think we're going to be able to or need to use, ERS for X amount of time, just to make sure that managed care could follow up, according to that timeline as well. But I think it's for everything, right? It's for transparency. It's also for, coordination and just making sure that everybody's on the same page when you're going into the circumstance.
Yeah, thank you for that, Richard. I wanted to highlight a comment from Christy from Day Out. She says ERS was used for the recent flooding in Merced County, and it was a perfect opportunity to support participants in a county-wide disaster and support the public health department and county effort. And that's exactly what we want to see. You all know how to do this, and you know your participants so well. So that's a great comment and observation to share, Chris. Denise, I know you had a comment you wanted to address that came in, I think, from Sunny Cal.
Yeah, sure. Thank you very much. So, well, there's a few that came from Sunny Cal. So thanks for your questions and comments. I'm not sure when we're going to get to all of them, but I did want to address one from Daly. Hi, Daly. Thanks for this. Asking about when there's an outbreak in ERS cases, are the managed care plans paying for this? So I want to just clarify a couple things. One, it sounds like from your question or comment, Daly, that you have heard that some plans are not covering, they're picking and choosing and whatnot. Do we know if this situation is true? First of all, I would just say, call your managed care plans, working on establishing relationships if you don't have them yet, and hear it from them what they need from you and how to work with you. So the managed care plans are working awfully hard to reach out to the providers, to understand how to work with this new part of the benefit, et cetera. So I'd say don't go on rumor, talk to them directly, to your contacts. And then the second part of that is that it's been very clearly stated in the all plan letters that the managed care plans get and in all the all center letters that the providers get that this new ERS, emergency remote services, is part of the CBAS benefit. Providers are required to provide it when the participants need it and when it is feasible and appropriate for it to be provided. So you're required to provide it like any of the other list of services, and then the managed care plans are required to cover it as part of the benefit. So that's just sort of fundamental part of the benefit. And then the managed care plans obviously always have jurisdiction over authorization. And if there's a determination that this is not a need that the individual needs, they need additional services, alternative services, et cetera, that is their job. And it's your job to work with them, help them understand things, et cetera. But there should be no sort of across the board, this is allowed, that's not allowed, this is allowed, this is not allowed. This is a very individualized, emergency-driven kind of a benefit. So I just want to clear that up, but talk to your managed care plans because they want to talk to you about this stuff. So don't go on rumors alone.
Communicate, communicate. You guys are in the communication business. You're in the relationship business. You're in the communication business, as well as the meal business and the transportation business and the health business. You guys have a lot of hats that you wear, but you guys know how to communicate. So, and it's building those relationships up. So great advice from Denise. Yes, LA Care just, Eliza says LA Care just did a webinar explaining the documents. If you're in LA County and didn't hear that webinar, be sure that you get their PowerPoint and recording, which should be out in about a week. It was excellent and provided amazing resources that you all should be aware of if you contract with any of the LA County Managed Care plans. So thank you for that, Eliza. All right, so a couple of these other comments are going to take a little longer to answer, but thank you. Keep putting your questions and comments in, everybody, because we will all scour them after this webinar is over, and they help us a lot. So just to conclude this segment of our webinar, some lessons learned. Make sure you study ACL 2208. Thank you, Denise, thoroughly. And as all of our presenters have said, use your best judgment to assess how cases are spreading. As Lois said, health and safety is your highest principle and value that you must always keep in mind. So apply your best judgment. And if you have any questions or concerns, your CDA analysts are available. Anyone on the vision team is available to talk things through with you. So please reach out to CADS. If you are a member, you know, we're here for you and can direct you to folks who can give you some support. And Lena, this last bullet is from you, so I wanted you to share your thoughts about what this whole experience has meant to you and what you've learned from it.
Thank you, Lydia. So yeah, my New Year's resolution is to start my day with gratitude and end my day with gratitude. I remind the staff, my coworkers, all the time, myself, that we know our participants best, and we practice safety and make decisions based on regulations and safety of the entire center. But it's definitely been very crazy since 2020. And so this year I am making sure that I remind myself that everything's going to be fine, and we're pros at this, and to just keep going, take each day at a time.
And that's your thought for the day. And I just want to encourage everyone to lean on each other, just as we did through the early parts of this epidemic. It was so important for us to be feel supported and part of a community that was experiencing the same thing. And that hasn't ended. We're still in that boat. So thank you, panel. We're going to go next, Renee, to natural disasters, because this is really current as well. The flu season and COVID have definitely taken its toll. I thought in December at some of our vision team meetings that we were like the tip of the iceberg. We had so many people ill, and the outbreaks were happening, and I'm glad to see it's starting to settle down according to the data. So Lois, of our team members, you were the one who was most immediately in the midst of this recent series of rain events. So I want you to share your experiences and what lessons you've learned. And I know you have a story to share from another colleague as well.
Thanks, Lydia. I do. The floods or storms were really quite an issue here in Santa Cruz, as I'm sure everybody saw in the newspaper. When I woke up on the morning of January 9th, my first thought was whether we were going to be okay to open the center. And I talked with my team and we decided we would go ahead, but keep watching the news very carefully. But by 8 o'clock in the morning, so just an hour and a half later, there was a warning that they expected flooding in our local area, and law enforcement was asking everybody to stay off the roads if they possibly could. So we decided that we needed to pause for the day, and we the team called all of the participants who were scheduled to come in, and found out what sort of immediate needs they had, and closed that day, and really didn't decide until we could see what was happening with the weather more until about 5 o'clock that day, whether to reopen again on Tuesday, which fortunately we were able to do. And I think one of the things that's important about that was that we did that without making a decision about ERS. What we did is we took care of the issue. We took care of the problem that was at hand. We called all the participants once in the morning, and we called everybody again in the afternoon. And it really wasn't until we knew that we were going to be only pausing for one day that we decided what we would do about ERS. And we decided at that point that for one day, we wouldn't do it because it was too difficult paperwork-wise to do that for one day of pause. What was also interesting, though, was that the same day, on the 9th, one of our vision team members from another center in Southern California had a really difficult situation, a challenging situation, which she hadn't anticipated. And that was that one of their participants who came into the center had his house flood while he was gone from the center, and not from the center, from his home. And he wasn't able to get back to his home. Roads in and out were closed. And the family did not have any friends or family near the center where he could stay. And they ended up having to make accommodation for him to actually stay at the center. And that was, I think, a big lesson for all of us on the vision team, all of the providers on the vision team, and that we really, really, really need to make sure that we are ready to deal with any disaster that happens, that we have our emergency planning in place, that we have our emergency supplies in place. What happened with the center in the south was that the gentleman stayed overnight. They borrowed a cot, stayed overnight. There were 2 of her staff members that volunteered to stay and stayed with him. And the really good part of the story was that at the end, the next morning, he said that he had had a great time, that is so CBAS. That is how we do things. It was a pretty difficult, challenging situation that turned into something good in the long run.
I think the exact quote was that he felt like he was on a vacation. So that was pretty incredible. So the ingenuity and the flexibility of our CBAS community springing into action. Thank you for sharing that, Lois, and your own experience. And I'm glad nothing worse happened in your neck of the woods. So we're going to move now from natural disaster to lessons learned. And this is really just a slide to give you a couple of resources. We want to remind you and any of our ADP providers who are on this webinar that all of you are required to have emergency or disaster plans in place, and to make sure that your team is trained to that plan, knows how to implement it, and is ready for any eventuality. We're going to see more of these extreme weather events in California, and we need to be ready for them. So here's a couple of resources, and there's some more at the very end of this PowerPoint presentation as well. If you're not familiar with Listos, they're a great resource, and they do have local resources that you can connect with, listoscalifornia.org. And then CDA ACL 1901, I know Lynn from CDA wanted me to mention that today. That is from 2019, and has a very great comprehensive, especially for those of you providers who are on the newer side, you might want to refresh yourselves as to that. I'll send her letter. Okay, Renee. So I'm going to bring the team back on again, our provider team, and we're going to shift gears now to personal emergencies. I think this has been the most confusing and complex area of implementing emergency remote services. And we're going to continue to learn and get better at this over time. But I want Lena, Richard, Lois, and Tatiana to share stories. We've grouped them into the key personal emergency buckets, if you will, that are identified in ACL 2208. So Lena, you're going to kick this one off for us.
Thank you, Lydia. I would like to share about a participant who was eligible for ERS because she ended up needing 24/7 oxygen. So when we initiated ERS for her, the entire MDT was on board providing care coordination. We needed to get her a portable oxygen machine, so we needed to coordinate care with the primary care physician, the pulmonologist of her choice, which was a whole deal. We initiated ERS for this member in November, and she is still on ERS because the care coordination that was needed to get this member back into the center needed all hands on deck. So we requested an order for a portable O2 machine. We needed to get her to those appointments. We needed her to honor those appointments, and there was preference with which pulmonologists she saw, so we had to make those arrangements. And then we had to get her proper transportation authorized to come to the center with her O2 machine. And with almost going on to 3 months now, finally, it looks like the last thing we're pending should be authorized any day now, and we're anticipating to get this member back into the center by February 1st. And in addition to the care coordination that we have been providing this member, one of the things that I'm most proud of is the communication amongst the MDT members. The social worker that was working closely with this case had to be off for a week because she had COVID. So one of the other social workers on staff just was able to pick up where she left off because our progress notes for ERS were so on point. And so maintaining that communication with the MDT has been very helpful, making sure we're navigating this ERS in a timely manner and getting the participant what she needs when she needs it to get her back into the center. I would also like to note that we have been keeping close communication with the managed care plan for this member, and it has been helpful with getting input from the managed care plan with maybe something we hadn't thought of. And so maintaining that communication with their managed care plan is also very important.
Okay, I'll take the illnesses and COVID-19 for the personal emergencies for ERS. I think for each center and for everybody that's still operating within the COVID-19 realm, even though it has been many years, I think we experience it in one of two ways usually for individual personal emergencies. Either the participant that we bring into our facility is tested positive on site if we are doing serial testing. And the other way that we usually encounter this is if the participant themselves reports to us that they have tested positive, after a family gathering or after symptoms. And the approach is pretty similar, I think, in terms of the reaction. And I think as kind of a sidebar, one of the questions that came in was, what's the difference between TAS and ERS? And I think this kind of highlights the difference itself is that with ERS, you're reacting to an emergency that has happened and, intervening so that that person, is able to receive services. I think TAS was more of a preventative thing. And so for ERS, it's very specific in terms of targeting the problems that we're trying to address that normally don't happen. And so especially with COVID, if someone does come down with COVID, you don't want them to give it to others and you want them to remain well and give them the services that they need until they get well. And so for this, I think the main things that we did was send a trained staff member to repeat test at the doorstep for the participant, just to make sure that they are okay. And then also have the nursing team and the social work team reach out to them to make sure that they are well, and that if they had any, conditions or symptomology that, we had to intervene on, that we would be available to do so. And so when a person gets COVID, thankfully, I think most people at our facility that have gotten it individually have been on the lighter side of the symptoms, although we did have people that did get sick a little bit more severely. But I think just keeping tabs on those and making sure that your staff are available and also responding so that the emergency can be resolved in a timely manner is very important, I think, when it comes to the personal emergencies aspect of ERS. And so for our center, just to repeat, it was just continued serial testing, and then also the spot test checking for participants that had tested COVID. And at the same time, the nursing team and the social work team, intervening based on the existing care plan that the participant has and any changes that may have, occurred in between, congregate services and when ERS was implemented as well. And so I think this COVID situation is going to continue. I don't think it's going to go away anytime soon. And I think for our center, it kind of, within ERS, it feels kind of funny sometimes because, at least in Los Angeles, I think we peaked sometime in mid to early December. And that's when everything started getting crazy again. But we kind of realized that it, kind of went down. So there was no, holiday surge, so to speak, that we were anticipating. And so going into ERS in that circumstance, it feels very urgent and it feels very scary. But when you look back on it, I think each provider might think, hey, did I really have to do that? But absolutely you had to, because I think you're dealing with situations as they occur, right? And I think the operative word that comes in when we're talking is judgment. It's not just judgment, right? It's not just like, hey, should I do this or that? I think it's more, you're using 2208, you're using the policy that exists and using your best clinical judgment with your clinical team as to what needs to happen right now to address these emergencies. And so for the personal emergencies with COVID, that's what I had to say. And I'll swing it over to Lois.
Thanks, Richard. So I'm going to talk just a little bit about a personal crisis as a reason for using ERS. And again, it's related to the floods. We have a participant who is diabetic, poorly controlled diabetic, and has fairly severe dementia. And his house flooded. And he and his wife moved out and are at a hotel right now. And she also has a bit of dementia and is has some difficulty caring for him at times. And she felt that she just being in a different location where they weren't used to, where he wasn't used to, that she just couldn't get him ready to come to the program. And we were concerned because he gets daily medications here at the program, and we were worried that she would have difficulty actually getting him his medication. So the nurses needed to call daily to make sure that he actually got his medication and to remind her if that was necessary, and also to make sure that he didn't have any symptoms that were worrisome at that point. The other thing is our social work team worked really closely with them to help them access the resources that are available for the flood, the disaster resources. There are a number of things available, but they've been changing kind of on a daily basis and are still changing. So those were the two things that we did that really fit under the ERS category for this participant. And I'll pass that on to Tatiana.
Thank you, Lois. So I'll go into what a care transition ERS case looked like for one of our participants. So following a fall at home on October 12th, we have an 89-year-old female participant who ended up in the ER, hospitalized and in need of a hip replacement, which happened on October 14th. So after that hip replacement happened, she was transferred to a rehab facility where she remained for a week. After that, she was transitioned back to her home, and the family requested that she be put on on emergency remote services. So that was on October 21st when she was discharged, and they requested emergency remote services. However, she was still too weak to return to in-center services and needed some additional time to regain her strength, build back stamina to be able to participate fully in a 4-hour day. So during her time on ERS, our nursing staff was able to closely communicate with the participant's family, her caregivers, and they were able to assess the participants' emerging needs and provide appropriate advice and health education via telehealth, as well as it gave our rehab staff an opportunity to coordinate with the participant's home health physical therapist to ensure that she would have that continuation of care when she did transition back to in-center services and to aid in that recovery. Well, on top of that, she was also provided with meals, activity packets, and we were able to physically see her during our doorstep checks when we did deliver those things to her. And following not so short, but a 7-week span of ERS, she was able back to return to congregate services, and she's still happily participating. So a wraparound of services. Back to Lydia.
Thank you again, everyone. Great stories, because I think they do illustrate how the things that are just fundamental to CBAS and even our adult day programs who aren't part of this ERS is that you guys know your participants so well, their families, all of their sort of what we call constellation of care around them. You can spring into action quickly and be flexible. And as you said, I think, Tatiana, you are able then to really provide a seamless continuity of care for that individual, so they're not being bounced around from one agency to another in the middle of an emergency. So I think we've also heard a lot more today about coordination with managed care as well, critical to making all this work. They're learning along with all of you out there. And we can see that that learning has improved over the last few months, and it will continue to. So let's go to the next slide, because we wanted to kind of summarize again some takeaways from these stories. So I'm going to pause here and just let our panel members maybe reflect on some of these thoughts and see if you want to add anything more to your descriptions of what you've learned.
This is Lois. I'll just jump on one of them about not letting the administrative burden scare you away from using ERS. I think one of the things, if people haven't used it yet, it is definitely a challenge to figure it out, make sure that you understand the ways that it can be used, and then just to figure out the paperwork, just to figure out how to use the Peach portal and how to fill out the SIF forms. But I can tell you that, you know, once you've done it a few times, it really is quite easy. I think the CDA has done a great job of making it as easy as possible, and hopefully over time, because we are learning that there may still be some changes coming forward that will make it even easier. So it really is, it's worth doing, and really, really helps your participants and your program to use it.
I'll just put a little note on what you've said to Lois, because Vision Team, as you all know, because you're on Vision Team, we have been discussing with the state how we might be able to simplify some things, make it a little more efficient to describe what's going on when there's a center-wide outbreak and a pause, how to make that a little bit easier on everyone, because you're dealing with an emergency at the same time. You're required to fill out a lot of paperwork. So I know Renee's going to talk about this a little bit. I did want to clarify one thing. I believe Denise answered it behind the scenes that Catherine brought up, Richard, for you, and that is clarifying that it is possible to use ERS for 1 or 2 participants who have COVID, and that doesn't necessarily mean that you have to decongregate the whole center or a group of people who are not sick themselves.
May I
Sure.
add to that? I think that the question maybe was partly about whether everybody had to be on ERS if you close. At least one of the questions was, and you don't. We had about 2/3 of our participants on ERS when we were paused for the outbreak. There were some people who really didn't have any need for services. They were okay. Most of those were people who were getting respite, and they didn't have any other particular needs at that time. So we evaluated everybody, but then didn't actually do ERS for everybody.
Thank you for clarifying that, Lois. All right. I think we've covered all of these points, but I'll give the panel one last moment if there's anything else you want to underscore before we move on.
Sure. I think point number 2, I think this kind of goes in line with, I don't know if it's in a later slide, but Renee said, I think her famous quote is, acronyms are for providers, not for participants. And when we're talking about tasks, when we're talking about ERS, and when we're implementing them for participants, I think it's very difficult to have participants understand the intricacies of the differences and of the terminology of what we're doing. And at the same time, it's not important to them what these words mean. It's more important that they are receiving the services that will in many times save their life or prevent hospitalization when there is an emergency. And so I don't think we should get bogged down with trying to educate participants what exactly ERS means. I think that's our job as providers to be able to do that and communicate that with CDA and MCOs and everybody in between. But I think with participants, you want to give them the services first, and then obviously you want their approval and their stamps going forward in terms of receiving these services, because that's also a requirement. But at the same time, I don't think we should be too concerned with the acronyms and kind of this terminology. But obviously, we want to do everything that we can as providers in moving forward with these services that are vital to our participants.
Very well said. Thank you. So thank you, panelists. We're going to, I believe now is time to move to talking about SIFs and discharges. Very important topic. Thank you again, all our panelists. So I'll turn this segment over now to Renee, who's been helping out behind the scenes. Thanks, Renee. And then we'll be wrapping up after that.
Oh, goodness.
Hey.
Hi. Oh, my God. Hi, guys.
Hello.
So sorry. Yeah, I had 3 screens and now I have one little teeny screen. So my apologies. Oh my gosh, I don't even want to look at myself on the camera.
We can see you just fine.
Oh, fantastic.
Fine. All right. So you're the closer today, and then you're going to hand it back.
Boy.
Okay.
Okay. So I'm here to, it's always so humbling to go after this incredible team of providers that talked about all the amazing things that they're doing today, because I mean, we are literally every single day all in the trenches, and everybody out in the audience is in the trenches too. I mean, it's so special and so humbling to do what we do every day. Absolutely incredible. So if you haven't given yourself a pat on the back, you should. Okay, pro tips, SIFs and reporting. So I know a lot of you, and by a lot I mean about 100 of you, haven't used the ERS benefit at your centers before. And so I wanted to kind of give you a quick rundown, because yeah, you probably heard there's a lot of steps, a lot of things that you need to do. So we put a whole bunch of links in here and a little step-by-step of what you need to do. And if you have any questions, don't ask me, ask Brett from CDA. So the first thing that you need to know is when you want to initiate ERS for one of your participants, if you think somebody is a good case for ERS, you need to log into the Peach Provider Portal. And they actually have a section for ERS. Most of your participants should already be in there. If you have some new ones, they won't be in there. But I put the link there for you for the Peach Provider Portal. If you don't know how to use the portal, that is A-okay, because if you click on the link below, there's some instructions on how to use it. Once you get onto that portal, if you don't know where you are, that's okay. A lot of people don't know where they are because you don't use it every day. So don't be hard on yourself. But in letter C here, you can click on ERS portal instructions, and it will literally show you where you need to go, where you shouldn't go to complete all of your ERS tasks. All right, so now let's see here on my teeny little screen. Okay, the next one. A lot of folks ask me, well, I don't want to log in if I have to do everything all at once and submit everything. Don't worry. The really, really cool thing about the Peach Provider Portal is you can start and you can pause. You can start putting in your information. You may have information that, you know, only you have, and then your nurse has information that only she or he has, and social worker. What I really, really recommend, and we did this at our center, it was a tag team effort with the team, you know, go ahead and get logins for the staff that can help you with this administrative task. They can go in, they can fill out information they know. Your CIF is always going to be in pending status until you decide to submit it. So this is a work in progress. It's a document in progress. So you have the ability to write a little, sign off, and come back. So really, really good way to minimize the administrative burden is to have help. Get the help of some of your super techie people so they can go in there and open up those cases, and then get help of your clinical staff to go in there and fill out information. And a big reminder, when you finish entering that CIF in the provider portal and you submit it so it's an active ERS case, remember that you can print that CIF out, and you have to communicate with the managed care plan. Send them the CIF. Let them know that you're initiating ERS for this participant. If your managed care plan calls you, do not be shocked. That's what they're supposed to do, because they want to know more about why you're initiating ERS. This is an opportunity for you to communicate. They want to know if they can provide any resources to that participant and how you guys can work as a team. So it's a really good thing. Don't be surprised. Don't be scared if they call. They're calling to coordinate. Okay. Remember, at the end, your job is not done there, because we need to, you know, I'm gonna back up a little bit. ERS is a demonstration project. It's an opportunity for us to demonstrate how this program can be beneficial to our participants, how this program can be molded to make sure it's more responsive to our participants. With that said, it's so important to understand the effects of this program, to understand how it's being used. And that was demonstrated so beautifully by Jennifer and Denise and Brett when you guys were giving statistics. I mean, it's incredible. We can see what's going on in our environments, in our cities, and the trends and how they're affecting healthcare and our participants' lives. When we are going to be, you know, talking about this waiver again at some point, if we want to keep this program, we have to show what it does. So it's so important for you to report. I know it's tedious. So number 4, remember, at the end of each month, when you submit your MSSR, your next job is to log into the Peach Provider Portal, and you have to mark the attendance days in the Peach Provider Portal for every single one of your participants. So the state knows, okay, you have these ERS cases and these participants received ERS on these days. It is a lot of work. If you have software, for those of you, you know, that do, you can pull reports, attendance reports, which make this a lot simpler. If you have software and you have no clue how to pull those reports, reach out to your vendors, send us an email, and we can perhaps point you in the right direction of how to pull those reports to make this data entry not so cumbersome, so everything is in front of you. Okay? All right. Let's see, pro tip, CIF share. Oh, sweet. Okay, so more for Brett. Here is the link to create more accounts for the Peach Provider Portal. And if you have any issues, you know, Brett will help you out. He's super nice to me. He's my tech, you know, he's my tech. I call him all the time. Okay, let's talk about discharge summaries. We've been hearing a lot of rumblings and musings and about discharge summaries. I have to tell you something. DHCS is requiring managed care plans to report on discharge participants. If you've noticed that you've gotten a lot of calls from managed care plans asking for discharge reports, discharge summaries, it is not just because you know, they want to put more work on you. It's because they are being asked this information, because they are also monitored, you know, by the state. The state wants to know, and the only way that plans can get this data is if you report it to them. So I know that there are various plans asking for data in various ways. However, there are simple ways to pull this data. All of us already submit a CDA discharge summary report to CDA. As long as we discharge people in our systems and we enter the information, pulling the report is a snap. It's a button. You know, as long as you keep up, you have to keep up. So when people are, you know, don't wait to discharge people, run reports, see who hasn't attended, do your discharges. Running those reports are really easy. The most beautiful thing is the CDA report is an Excel report. You can filter it by payer. That way you can always provide this data to each payer separately. If you use Turbo, you can get that discharge report with a click of a button. If you don't know what you're doing, if you just haven't done this in a while, send an email to us. We'll help you out. We'll send you a video link on the instructions and exactly how to do it. I did want to say something about LA Care, because I know that the wonderful folks over there had a webinar yesterday, and I know that they're asking some additional information. I'm waiting on those slides, but if you keep information about your participants in your electronic medical record, hopefully we can find out what information is needed and how to pull it out of there. I know our progress notes contain a lot of information. So as we learn more about what each plan wants, we can address those questions. But right now, at the very least, if you have not communicated with your managed care plan about discharges, please pull the report for them. I know that a lot of them are trying really hard to get this information so they can report it. So let's work together for a common goal, as I think we always do. I always think about that. We all have a common goal, and make sure that we help each other get what we need so we can return to doing what we do best. I think that's it. Do I have anything else? Oh, tag team. Oh yeah. Tag team, we talked about tag teams. Oh, templates. If you're not ready to go online and you want to just start jotting things down, there's an awesome template. I put a link here in the system where you can actually go ahead and start, you know, putting in the information. And then when you're ready to go online and actually enter that information, you can go ahead and, you know, put it in. So whatever way you want to do it, whatever order is easiest for you, there's a tool out there, because we understand that some people may not be computer, you know, savvy. You can still get that information down and give it to somebody else to put in. Let's see here. Have a template. Gosh, I got to remember what I wrote here. Have a template ready for recording progress notes. Yes, yes, yes. Reasons, mode. Let's see. Did I get on somebody else's slide?
Renee, I think these were some of the tips from our providers, the rest of the panel that we summarized here on this one. That's why.
All right, I'm going to skedaddle then.
That's why they're not your words.
I knew it.
But thank you for overviewing this slide. We are getting near the end of time, so I am going to have you move us on. Thank you, Renee, as always, for all the work that you do. I know your help desk is busy, busy, busy.
My pleasure.
I just wanted to start closing us out here, everyone. Today we'll go over about maybe 2 minutes at max, just to reiterate what CADS is doing to help you. It's been a busy start to the new year, the year of the rabbit, which by the way is me, so this should be my good lucky year. We are working, committees are getting organized. We're going to be working under Tatiana's guidance to develop webinars for the year. We've got some fantastic ideas already coming forth. do send us ideas. Love to hear from you, or put it in your evaluation. Let us know what you're interested in learning about. We continue to have monthly meetings with all the major managed care plans. Those have been extremely useful through all of these transitions and helping with communication. Vision team is working to try to refine some of the areas of concern that have been raised by many of you and even within the Vision team about ERS. So it takes a little while to work these things through and discuss them, and we'll keep everyone posted on that. Master Plan for Aging, there's an initiative that we've started working on to help identify what barriers to accessing CBAS is. So that's an exciting project for this year and maybe even into 24. Grassroots advocacy, our learning community for CalAIM is up and running under Lena's leadership. If you want to learn more about how you can work with your managed care plan to provide some new lines of business that will help your members and their members, please let us know. This is open to CADS members only at this time. The Bridge to Recovery grant funds, there will be some more news coming out about that soon. And there should be some payments coming out for staff under the federal ARPA COVID funding that has been provided to the state of California for staff in CBAS and MSSP, but we're not clear on the status of that yet. We're continuing to try to find out from the Department of Healthcare when you can expect those. And we're very excited about the new CADS Connect portal that is going to allow members to communicate with each other in real time more quickly. We'll set up peer groups. It's a very exciting rollout this year. So again, if you're a CADS member, more to come on that. And the other exciting thing, we are hosting some facilitated listening sessions with CADS members as well as non-members. So a selected group of non-members will receive an invitation to participate in that over the next few days. And those are scheduled for mid-February. So with that, I want to just close out by, go ahead, Renee, by bringing your attention to this amazing list of resources that the Department of Aging shared with us and that I have put into these slides. We're not going to go over each one of them, but I just want you to know these are all clickable links. So please download that PowerPoint, load it back up again. Download the PowerPoint that Danielle sent to you this morning prior to the webinar starting so that you can download this and use these clickable links. So go ahead and just quickly browse through those so people can see COVID. Next one, Renee. Some flu and COVID resources. A couple of them I mentioned earlier. These are some other ones. Face masks is on here. Someone earlier asked about face masks, so there you go. Go ahead. Face masks are required in healthcare facilities, and you are a healthcare facility if you're an ADHC. Some additional resources for local health, infection control. Go ahead, Renee. CBAS All Center letters, nicely organized for you. Next. And then ERS resources on this slide, and I believe the next one. This is reporting resources. So there's a lot. Any of you who are newer centers, I know you're probably feeling a little, or have new staff, probably feeling a little overwhelmed, but again, you know, reach out to any of us for assistance. We're happy to help you. And Renee's famous takeaway saying today is always use your best judgment. So thank you, everyone. Have a great weekend. Have a restful weekend. Be safe, stay well. And comments are always welcome at Department of Aging and Department of Healthcare Services, as well as to our office here, cads@cads.org, or you can contact me directly, Lydia@cads.org. If you're a non-member, this is the year to join, people. Lots going on, and you'll be in the know if you're a member, and you'll have access to all these great resources that we can provide to you. So, Renee?
My last plug.
I know you always have to have the last word somehow.
No, it's about membership. It's so important. I sent out this webinar link to so many of you today, and I got a peek at the non-member list. And so I'm here to remind you, if you like this webinar and you like sharing and you like having your voice heard, please do join CADS. it's invaluable. We appreciate your feedback. Yeah, support Danielle over there.
And this is the woman,
Thanks,
Danielle,
Renee.
who will support you through that process. Danielle, you want to put
Yes.
in the last word?
Oh, no, definitely check out the website if you have any questions about joining. If you're wanting to know more about the Connect portal, give us a call, email me. I'd love to talk to you. Thanks, Renee, for the plug.
All right. Again, thank you, everyone. Have an enjoyable weekend and be safe. Bye-bye.